Good afternoon, all. So I hope you are hearing me. And we are towards the end of autonomic nervous system, and this will be their last topic, that is the drugs used in glaucoma. So we have discussed some part of glaucoma while discussing, especially the cholinergic system. It came along with the pilocarpine, phytostimulant, etc. So glaucoma is a condition in which the intraocular pressure is very much increased, and this increase in intraocular pressure is may occur due to two reasons: either there is increase in secretion or production of the aqueous humor, or the decrease in the drainage of the aqueous humor. So why this glaucoma is important? Because so in Nepali we call it Jala Bindu. So there is increase in aqueous humor accumulation inside the eye. So increase in this aqueous humor accumulation inside the eye will cause constant pressure in the optic nerve, and constant pressure in this optic nerve can lead to blindness. So there are different therapies that are used in the treatment of the glaucoma. So we'll be discussing about those drugs, about those therapies in this chapter. So it is a disease which is characterized by progressive form of optic nerve damage, and it occurs as a result of constant buildup of pressure from the increased accumulation of the aqueous humor inside the optic chamber, and this is generally but not necessarily associated with raised intraocular tension. So increase in this aqueous humor accumulation inside the optic chamber will lead to the increase in intraocular pressure, but there may or may not be increase in intraocular pressure, but there will be always increase in aqueous humor production or decrease in secretion. So what are therapeutic measures that are given to control, that are given as a therapy in the treatment of the glaucoma? So this increase in intraocular pressure should be lowered either by decreasing the secretion or production of the aqueous humor, or by promoting the drainage of the aqueous humor. So there are two approaches in the treatment of the glaucoma. So first is the either you reduce the secretion or production of the aqueous humor, or you increase or promote the drainage of the aqueous humor. So aqueous humor production. So this is the figure showing how the aqueous humor is produced, and how this aqueous humor produced in the posterior chamber is moved or flow towards the anterior chamber. So aqueous humor production occurs in the ciliary process, so in the posterior chamber. So after the production of the aqueous humor in the ciliary process in the posterior chamber, it is moved towards the anterior chamber via the pupil. And in the anterior chamber, there are two major pathways for the drainage of this aqueous humor. So one is the trabecular pathway. So in the trabecular pathway, there is the presence of the canal of Schlems or Schlems canals, which are responsible for draining 90% of the aqueous humor. And there is another pathway which is known as the uveoscalar pathway. So this uveoscalar pathway is responsible for drainage of 10% of the total aqueous humor. So there are two important pathways. One is the trabecular pathway and the other one is the uveoscalar pathway. So as I said earlier, this aqueous humor production occurs in the ciliary process. So ciliary process is responsible for production of the aqueous humor, and through the pupil. So this aqueous humor that is produced in the posterior chamber is moved towards the anterior chamber. So there are two different pathways. One is the trabecular meshwork. The other one is the uveoscalar pathway. So in the trabecular meshwork, there's presence of the Schlems canal or the canal of Schlemm. So this aqueous humor that reaches towards the trabecular meshwork and the canal of the Schlemms is drained by the collector channels, and this is the conventional pathway, and 90% of the total aqueous humor is drained via this pathway, that is the trabecular outflow. And 10% is responsible for draining 10% of this aqueous humor is drained via the uveoscalar outflow, and the aqueous humor that's produced in the posterior chamber move towards the anterior chamber, and in the anterior chamber it moves. So from the posterior chamber, it also moves towards the anterior chamber in case of uveoscalar pathway. So in this uveoscalar pathway, the aqueous humor that comes towards the anterior chamber, again goes towards the ciliary muscle, and after moving towards the ciliary muscle or the ciliary body, it is drained by the suprachoroid space, and there is a venous circulation in the ciliary body, choroid and sclera, and this forms the UVA scalar pathway. So one is the trabecular outflow, so it forms 90% of the total drainage, and the other one is the UV scalar outflow, which forms the 10% of the total drainage of this aqueous humor. And coming to the types of glaucoma, there are two types of glaucoma. So you can see here there are two types of glaucoma. So one is the open angle. So in the left hand side you can see the open angle. In the right hand side you can see the close angle or angle closure, which is also known as the narrow angle glaucoma. So narrow angle glaucoma is responsible for draining 90% of the total aqueous humor, whereas narrow angle glaucoma is responsible for 10% of the glaucoma. And what you can see the difference here in this picture. So in between the open angle glaucoma and the narrow angle glaucoma, so in the open angle glaucoma, the angle between the iris and cornea is wide or it is open. So the angle between the iris and cornea is open, it is wide. So open angle glaucoma is also known as wide angle glaucoma. And whereas in narrow angle glaucoma, the same angle between the iris and cornea has been decreased very much. And so the main pathology behind this open angle glaucoma is within the trabecular meshwork. So you know this trabecular meshwork is responsible for draining 90% of the total aqueous humor. So the main pathogenesis in open angle glaucoma lies within the trabecular meshwork. So since it is a trabecular meshwork, so with the increasing age, there is a degeneration of the trabecular meshwork, and hence since there is a degeneration of this trabecular meshwork, so canal of Slem's also becomes degenerated, and enough or sufficient amount of the aqueous humor drainage doesn't occur. Whereas in narrow angle glaucoma, so the main pathogenesis is because of the trabecular meshwork, and yes, there was some internet disruption, so we were on this. So there are two types of glaucoma. So one is the open angle glaucoma, the other one is the close angle glaucoma. And when we talk about the prevalence of these different types of glaucoma, open angle glaucoma occurs in 95% of the cases. So 90% of the 90% of the total glaucoma is the open angle glaucoma, whereas 10% of all the glaucoma is narrow angle glaucoma or angle closed glaucoma. And the main pathogenesis behind the open angle glaucoma is within the trabecular outflow, because with the increase in age of the patient, there is a degeneration of this trabecular meshwork, and the aqueous humor, the aqueous humor that is drained by this canal of Slem or the trabecular meshwork, that is suffered. And whereas in angle closed glaucoma or the narrow angle glaucoma, the main pathogenesis lies between the here. So it is the angle between the iris and the cornea. So the iris and the angle between the iris and the cornea is very much narrowed, and hence the aqueous humor that's produced in the posterior chamber by the ciliary process. So it cannot go towards the anterior chamber, and there does not occur the proper drainage of the aqueous humor. So coming to different types of glaucoma. So now the first one is the open angle glaucoma, which is also known as wide angle glaucoma, and it's also known as the chronic or the simple glaucoma. But when you talk about the severity, so although the incidence prevalence of open angle glaucoma is more when compared to the narrow angle glaucoma, the severity of narrow angle glaucoma is much more severe than the open angle glaucoma, as well as the prognosis of narrow angle glaucoma is poor when compared to open angle glaucoma. So now going towards the each of this glaucoma and treatment of each of this type of glaucoma. So the first one is the open angle glaucoma, which is also known as wide angle chronic simple glaucoma, and it is a genetically predisposed degenerative disease, and so it occurs via the increasing age, and it is also the genetically predisposed. So it affects the patency of the trabecular meshwork, which is lost, which is gradually lost past the middle age of the patient, and the IoT increases progressively because there is a decrease in drainage of the aqueous humor via the glaucoma. The mainstay of the treatment is the ocular hypotensive drugs. So ocular hypotensive drugs are used on the long-term basis, and they constitute the definitive treatment in majority of the cases of the open-angle glaucoma. So what are the drugs that are used for the treatment of glaucoma? And these used for the treatment of both the open-angle glaucoma as well as the narrow-angle glaucoma. So there are two different approaches for the treatment of glaucoma. So one approach is to decrease the aqueous humor secretion, and another approach is to increase the aqueous outflow or increasing the drainage of the aqueous humor. So what are the drugs that are involved to decrease the aqueous humor secretion? So they include the beta blockers. So it may be cardioselective beta blockers like beta-stolol, or non-cardioselective beta blockers, or non-selective beta blockers like timolol or cardiolol, and alpha agonists like dipiveprin, brimonidine, apraclonidine, and carbonic anhydrase inhibitors, so acetazolamide, dorzolamide, and brinzolamide. And similarly, the next approach, which includes the increase in the aqueous humor outflow, or increase the drugs that include the drainage of the aqueous humor. So the drugs that increases the trabecular outflow includes like myotics such as pilocarpine and pyzostepine, which we have studied in cholinergic section, and alpha-2 agonists like dipiveprin. And the group of drugs that increases the uvascular outflow include the latinoprost and bimatoprost. So going towards the treatment or therapy approach for the treatment of open-angle glaucoma. So we'll go towards the different, now we are moving towards the different drugs that are used for the treatment of open-angle glaucoma or the wide-angle glaucoma. So you can see in this picture that there's a process of the ciliary epithelium, and this ciliary epithelium consists of different receptors. So you can see here beta-2 receptors, you can also see here alpha-2 receptors, and there's also presence of alpha-1 receptors. So all the drugs that are used for the treatment of this, either the close-angle glaucoma or the open-angle glaucoma, are related to these receptors. So now moving towards the first drug for the treatment of wide-angle glaucoma or open-angle glaucoma is the beta blockers. So you can see here the beta-2 receptor, presence of beta-2 receptor on the ciliary epithelium. And when this beta-2 receptors is, what does it do? It increases the production of the aqueous humor. So when the beta-2 receptors are stimulated, so which is present on the ciliary epithelium, it results in the increase in formation, it results in increase in secretion of the aqueous humor, and this increases the amount of second messenger, that is the CAMP. And when you give beta blockers, so obviously they will block these beta-2 receptors that are present on the ciliary epithelium, and now will block or inhibit the production of the aqueous humor. So beta blockers are used for the treatment of the as opposed to the open angle glaucoma, which decreases the aqueous humor production, which decreases the aqueous humor secretion.
मैम एकचोटि फेरि भनिदिनु न हजुरको
So when we talk about the
कट
first
भइरहेको
choice drug in the treatment of open angle glaucoma, it is the prostaglandin analog. How okay. You can listen to me now. अलिकति इन्टरनेट खासै राम्रो छैन जस्तो लाग्यो आज. So we were talking about the drugs. So you know that two different types of glaucoma, open angle glaucoma and the closed angle glaucoma. So we are talking talking about the open angle glaucoma, secret glaucoma. Open angle glaucoma, so aqueous production, the aqueous tumor production via the ciliary epithelium. And the ciliary epithelium, you can see different receptors like beta 2 receptors and alpha. And so all remember, so when beta 2 receptors that are present on the ciliary epithelium are stimulated, so it increases the level of the aqueous tumor production or the secretion, and this CMP. And we are giving here the beta blockers. So why we are giving here beta blockers? Because it is the group of drugs which will now block the beta 2 receptors, or it can be blockade of beta 1 receptors as well if we are using the non-selective beta blockers. So blockade of this beta 2 receptors that are present on the ciliary epithelium by the use of beta blockers. So what does it do? So it decreases the aqueous tumor production by decreasing the level of the second messenger CAMP, and hence we give the drug that is the beta blockers in the treatment of open angle glaucoma, in which there is increased production or secretion of the aqueous humor, because this group of drugs decreases the production and secretion of the aqueous humor by blocking the beta 2 receptors on the ciliary epithelium. So when we talk about this different drug approaches, different treatment approaches for the treatment of open angle glaucoma. So first choice drug is the prostaglandin analog. So we'll come on that. So first choice drug for the treatment of open angle glaucoma is the prostaglandin analogs, यो PGF2 alpha analogs भनेर भनिन्छ. So that is the prostaglandin analogs. However, पहिला चाहिँ नि topical beta blockers were the first choice drug for the treatment of the open angle glaucoma. So topical beta blockers have been the first line drugs till recently, but nowadays prostaglandin F2 alpha analogs are the preferred drug for the treatment of wide angle glaucoma or the open angle glaucoma. So what is the mechanism of action of this beta blockers in the treatment of open angle glaucoma? So they lower intraocular tension or pressure by reducing aqueous humor formation. So by blocking the beta 2 receptors that are present on the ciliary epithelium. And when beta 2 receptors on the ciliary epithelium is blocked, inhibited, so this inhibits the formation of CAMP in the ciliary epithelium, and now this will lead to the decrease in aqueous humor production or secretion. And the use of beta blockers, topical given in the form of eye drop. In fact, most of the drugs that are used for the treatment of glaucoma are given in the form of eye drop. So when we give beta blockers topically or in the form of eye drop, it produces these ocular side effects, and it does not affect the size of the pupil. It does not affect the tone of the ciliary muscle. So if you remember the cholinergic drugs like pilocarpine or physostigmine, they were the cholinergic group of drugs, and they had affected the pupil size because they causes the miosis, and they also this cholinergic group of drugs like pilocarpine and physostigmine also increases the tone of the ciliary muscle, or they produces the ciliary muscle spasm. So, however, the beta blockers are free done by the cholinergic drugs like pilocarpine or physostigmine. And ocular beta blockers or the topical beta blockers are lipophilic and with high ocular capture. And this is in order to reduce the systemic toxicity or systemic side effects. So what are the ocular side effects of beta blockers when they are given via the eye drop or the topical application of beta blockers is done? So they are generally mild and infrequent, which can cause stinging, redness, dryness of the eye, and the blurred vision. However, this occurs usually by the absorption of this drug through the nasolacrimal duct. So when the topical beta blockers is given via the eye drop, so some of the drug can be absorbed via the nasolacrimal duct, and lacrimal duct can occur, which can result in and can cause the systemic adverse effect. And most important systemic side effects is that this has been reported in when used in the asthmatic and the COPD patients. So this happens most frequently when these non-selective beta blockers are being used as a topical eye drop or topical hypotensive drugs. So why these life-threatening bronchoscopy beta 2 receptors, and beta 2 receptors are also present in the bronchioles of the lung. So when the bronchioles when the beta 2 receptors that are present in the bronchioles are blocked, so it will cause bronchospasm, it will cause the bronchoconstriction, and then they can cause the bronchospasm towards the asthma. So can be that in the heart by the blockade of the beta 1 receptors in the heart. It again due to the block of the beta 1 receptors. Beta 1 receptors in the.
Excuse me, ma'am. Can you सुनाई रहा है